Right. It's 2 o'clock here in the UK. So I thought we can just make a start to make sure that we have time for the presentation and then questions. I'd like to introduce you to Dr. James Evans. James is going to present an overview of his PhD. He completed his PhD in 2023, and it's a mixed methods approach to research, investigating complications, clinical outcomes, and also family experiences about the use of gastrostomy versus nasogastric tube feeding in pediatric bone marrow transplant. And just a little bit about James. He works in London, Great Street Ormond Hospital, award-winning dietitian with a lot of experience, over 10 years of experience. Just a few things about the educational session. So it is an hour overall. We'll start with James' presentation, and then we'll allow some time for questions at the end. James, are you quite happy to share the slides?
Yes, thanks, Raquel. I'll share my screen. Thank you. Okay.
Excellent.
Lovely. Thank you, Raquel, very much for the
I can see well the slides. Lovely.
Okay. Thank you. Well, good afternoon, everyone. I will reintroduce myself. So I'm James. I'm a paediatric dietitian specialising in bone marrow transplants at Great Ormond Street Children's Hospital in London. I also work as the research lead for dietetics at University College London Hospitals as well. So this nice mix of research and clinical practice. And thanks for the invitation to speak to the SIOP Nutrition Network today. And I'll be presenting my PhD research, which I completed last year. And I've been working on this project really since about 2018, so some years in the making. And it was a mixed method study looking at nutritional outcomes and family experiences of gastrostomy feeding particularly, but comparing that to nasogastric tube feeding in pediatric bone marrow transplants. And this was funded by the National Institute for Health Research. So I'll speak for about 45 minutes or so to allow some time for questions. So the structure of the talk is as follows. So I'll start by a bit of background to bone marrow transplant, BMT at Great Ormond Street, where I work, and then briefly outline the nutritional issues that children having a BMT face. I'll then outline the problem that I was trying to address in this research. I'll state the 4 objectives that I was addressing in the research, and then briefly go through the study design that was used to meet those objectives. And the study design really consisted of 4 separate projects called work packages. And I'll briefly go through the methods that we use for each of those 4 work packages and summarize the findings, and then pull everything together at the end for the conclusions and the recommendations that we made. So to begin firstly with a bit of background to BMT at Great Ormond Street. So we see children for allogeneic BMT that are seen in many other BMT centres internationally. The largest proportion of children that we see have various primary immunodeficiency syndromes. The next largest proportion have various relapse leukemias. And then we see much smaller numbers of children with a whole range of other conditions, certain metabolic conditions like Hurler syndrome, certain gastric conditions as well. Of about 12 or 13 centres across the UK that do allo BMTs, we're the largest. So we do somewhere in the region of 60 to 70 allo BMTs per year. And I specifically mentioned allo BMTs because that was the type of transplant this project was focusing on. And we do see the little ones at Great Ormond Street. So we see children from a few weeks or months old up until about 13. So we tend not to see the teenagers and young adults they're transplanted elsewhere. Okay, so I'll just summarize the nutritional issues that children having BMT face here. So as we all know, these children are at very high risk of developing malnutrition from a range of issues during the BMT process. Firstly, a whole range of gastrointestinal side effects from their conditioning, including anorexia, taste changes, nausea, vomiting, diarrhea, and of course mucositis. And that's before you even get into the complications that they can run into post-BMT, including graft-versus-host disease, GVHD, infections, and a whole range of other complications as well. So the research has associated malnutrition with the development of a number of poor outcomes, including GVHD, greater risk of relapse, and even poorer survival. So needless to say, optimal nutritional care is absolutely essential to these children. So the problem that I was trying to address in this project goes like this. So for all of our children that we see having allo BMT at Grace Ormond Street, their oral intake becomes insufficient to meet their nutritional requirements. So really the next intervention that we use to provide nutrition support is enteral tube feeding rather than parenteral nutrition that's used in some other centres. So we try and feed our children once their oral intake stops via enteral tube feeding. And to that end, most families at our centre are offered a choice between one of two feeding tubes. And they make this choice over a number of pre-admission consultations before the child's even admitted for their BMT. So these take place over a number of months before the child's admitted. And then with the BMT MDT, including their medical consultants, clinical nurse specialists, and of course the dietitians get some time with the families as well. So during these meetings, the families are prepared for all aspects of what to expect during BMT, and nutrition is a really big part of this, and they're given this choice of tubes. So if they want, they can choose a nasogastric tube. Currently the mainstay used most widely in our centre, and it's the tube that's used most widely in reports in the literature. Of course, there are pros and cons to this tube that we all know. So pro, they can be placed relatively easily on the ward by nurses, but the cons are that they're not fixed in place. They can be frequently dislodged due to vomiting in this population. And of course, they're visible on the face, which can be aesthetically not particularly agreeable with some children and their parents. Now, if families want, they can choose an alternative, a gastrostomy, and these are typically PEGs in our centre. And if the families choose this, these are placed prophylactically in the weeks prior to admission to allow the stoma that's created time to heal before the child becomes neutropenic during their BMT. Again, there are pros and cons to this tube. The pro, they're hidden under the clothing, so aesthetically they can be preferential for some of the older children. They're fixed in place so they won't be dislodged. But of course, there's the cons of the surgery that's needed for placement and the risk of infection as well. So this has been standard practice at our centre for decades, and it's always been something that's really fascinated me and continues to do so. And when I was conceptualising this project in 2018, there was a whole range of issues we didn't know about this. So we didn't know how safe gastrostomies were in this particular population, who were obviously at very high risk of infection. We didn't know outside of Great Ormond Street which other centres used gastrostomies and which didn't. We didn't know how their outcomes compared. Clearly, we get asked that question all the time from parents, is one better than the other? We didn't know. We didn't really have the evidence back some years ago now. And we really didn't know more than anecdotally why parents chose one tube or the other. So that needed some exploration. And we don't know how the day-to-day lived experience compares for families that have either of these two tubes as well. Is it that some of the families that chose the PEG really regretted their decision, and some that had the NG did really well with it? Some might have preferred the NG. We just didn't know. So there's a whole range of didn't knows when we were conceptualizing this project. So this was really important to me. It was something that I found interesting. But when I was developing the project, of course, I needed to see whether it was important to others. And we tackled that on 3 areas. So we did the patient and public involvement work, the PPI work. We looked at the evidence, and we looked at policy as well. So I'll just summarize those 3 points here, starting with the PPI. So I did some focus groups with our BMT nurses on the wards at Great Ormond Street and our national oncology, UK oncology dietitians group as well. And the feeling from the nurses and dietitians was that more children would benefit from the use of gastrostomy. So they were keen to use it more, but it seemed that they were seldom used in other UK centres, with the biggest barrier to their wider use, this concern about the risk of infection in this particular population. I also did some interviews with some parents and children who were on the ward having their BMT at Great Ormond Street. And these were children that had some gastrostomies. And these were just quite informal interviews, just talking to them about their experiences. And they largely reported very positive experiences of having their gastrostomy. So immediately then I was thinking, okay, maybe other families at Great Ormond Street and outside of our centre, of course, might benefit from this intervention. We also looked at what the evidence base was in 2018. So this was very minimal, really, regarding this particular topic. So the evidence regarding the safety, the complications of gastrostomy feeding was conflicting through a kind of scoping search. So there were some studies that had shown them to be associated with greater risk of infection in BMT, but others had shown them to be associated with mostly minor complications. So there was a need to systematically review that literature. The evidence regarding decision-making in this context was completely absent. Most of the papers here had seemed to focus on the decision-making and experiences of parents actually looking after their child's gastrostomy. And this was mainly with children with neurological disability rather than going through cancer treatment or BMT. And the evidence back in 2018 regarding how these tubes compare in terms of nutritional outcomes was absolutely limited. There was nothing really. And I'll just highlight a few more recent studies that are starting to look at the use of gastrostomies in BMT, and these are generally showing positive associations between gastrostomies and a whole range of transplant outcomes. And finally, on policy, we linked it in with some priorities from the James Lind Alliance and our NHS long-term plan, which recommended research to look at ways of improving children getting back to normal life following transplant and improving outcomes as well. So we could certainly link that in with those policy. Okay, so the gaps in the evidence, the positive findings from the PPI and linking in with policy informed the 4 objectives for this study. So the first was to systematically review the literature for the complications and outcomes of gastrostomy feeding. No previous systematic review had done that. The second was to do the national survey, so look at gastrostomy use and scope that across the UK, which centres are using it and which ones aren't, and also explore the opinions of clinicians towards gastrostomies. The third was to do a cohort study prospectively to look at complications of gastrostomies and produce more evidence on outcomes comparing gastrostomies and nasogastric tubes. And the fourth and final one was to do the qualitative work, so to do the interviews with parents and children to explore why they chose one tube or the other and how their day-to-day lived experiences of either tube compared. So the study designed to meet those 4 objectives was a multi-phase mixed method study to shed light on this topic from multiple perspectives, which I thought was really what was needed here and the best way of investigating this concept. So there were 2 phases. The first phase contained the first 2 objectives, so the systematic review and the national survey, and they were positioned early on in the PhD to inform phase 2, which was the heart, really, the core of this mixed method study. So it was the quantitative cohort study running in parallel to the qualitative family interviews. And this is just a quick slide showing really how each of these work packages and objectives fitted together. So as I said, the systematic review and national survey were done first, and the purpose of that was to develop the cohort study and the interview. So for example, in the survey, we told the clinicians that we were going to do a cohort study and interview some families. So I asked them in the survey, what outcomes would you like me to investigate? With the intention that if I produce some data on that outcomes, that might influence change in practice potentially in those centres. And I also asked them, what would you like me to talk about with the parents and children in the interviews? The link between the cohort study and the interviews was one of triangulation, so it allowed comparison of the quantitative and qualitative findings. And then the links between all the different parts of the research were enhancing and clarifying the results from all the different methods to give a really thorough understanding of this method from lots of different perspectives. So I'll go through each of the 4 work packages, objectives now in turn, and just briefly outline how we did them and what the main findings were, and then pull everything together towards the end. So starting with the systematic review in phase 1. So the question that we were specifically addressing in this systematic review was, what are the complications and outcomes associated with the use of gastrostomies in children undergoing BMT? So that was the main population that we were looking at. But as I said, a scoping search early on revealed that there was just not enough papers to look at that specific population on its own. So we expanded the population to include any studies that had really looked at the use of gastrostomies in children undergoing cancer treatment, but not necessarily with BMT. And clearly these children are at a similarly high risk. So we wrote the protocol according to PRISMA-P, and we registered that on Prospero. We searched a range of relevant databases, And articles that were retrieved from the database searches were independently double screened by myself and Brianna Gardner, one of my colleagues at Great Ormond Street. And then we extracted the data and did the risk of bias assessments using some appropriate tools. And this is a list of the studies that we finally included. So there were no randomized studies here, which was a limitation of this evidence. There was a number of cohort studies that compared two groups, and that was either children that had a gastrostomy for BMT compared to a nasogastric tube, or children that had a gastrostomy for BMT, and they compared outcomes, for example, the frequency of infections in another group, a control group of children that had gastrostomies but were not undergoing BMT, for example, children with neurological disability. But most of the studies were case series, just following one group of children over time and just reporting their outcomes. So as you can see here, the risk of bias assessments here showed these studies generally to be of low to kind of moderate quality. Most of these studies were retrospective on small samples. None of them were randomized. And there was wide differences really in the way that outcomes were described and reported between these studies. But it was possible to pull the data and give a summary of the results here. So looking at the complications with gastrostomies here, so about 40% of children from these studies that had a gastrostomy were reported to have absolutely no problems, no complications at all with them. About 60% of children that had a gastrostomy did develop at least one or more complications. But of those that did, most of these complications, about 80% were minor, very, very easily treated. Only about 20% were classified as being quite major gastrostomy complications, generally quite serious infections that needed either gastrostomy removal or treatment with intravenous antibiotics. The most frequent gastrostomy complications were infection and inflammation of the stoma site and leakage of the gastrostomy device. And regarding nutritional status, this was measured using a whole range of different methods: weight change, percentage weight change, BMI, mid-upper arm circumference. But gastrostomy feeding generally was associated with improvement or stabilization of nutritional status using all these different methods in the majority of children. And we did summarize all the different methods, measures of nutritional status that we used in the paper that we finally published, and I'll touch on that at the end. So generally, from the systematic review, the results towards gastrostomies did look relatively positive, associated with frequent, mostly minor infections, and supported the children's nutritional status well, but with a big caveat that these findings were based on mostly moderate level evidence, mainly in cancer populations. Only about 2 or 3 of these studies were specifically in children that had undergone BMT. Okay, so moving on now to the second part of phase 1. So this was the National UK Survey. So there were 2 aims here. So the first was to understand gastrostomy use across UK paediatric allo-BMT centres. So which centres are using them and why do they use them, and which centres are not using them and why are they not using them. And second was to compare opinions toward gastrostomies between what we deem to be the decision makers really when it comes to nutrition support in BMT, the dietitians, the clinical nurse specialists, and the medical consultants, the physicians. So all paediatric centres across the UK were invited to take part, of which there were 12 at that time. And they were invited to complete this bespoke online survey that was designed using some similar surveys in this area. And within each of those 12 centres, the survey was completed by 3 people. So the lead BMT dietitian and the lead BMT clinical nurse specialist and the lead BMT medical consultant. Now, for some centres where they have multiple dietitians and nurses, for example, that particular clinical group was asked to give a combined collective response. And we eventually got a 100% response rate from all the 36 clinicians. So the participants were given a month to complete the survey. And from our ethical approval, we were allowed to chase up via some emails and phone calls, but we did get a response from everyone eventually. And a summary of results are as follows. So looking at the use of gastrostomies across the UK first. So about 40% of centres said they used them in some children. The majority, about 60%, said they didn't use gastrostomies in this patient group. But really interestingly, in these centres that were not currently using gastrostomies, clinicians, about 3/4 of the clinicians, 3/4 felt that some children should be offered a prophylactic gastrostomy for BMT, even though their centre currently wasn't offering that. 14% felt that all children should be offered a gastrostomy as a blanket policy. Only 10% felt they shouldn't be used in this population. And in the centres that were using gastrostomies, they were mostly used in children with a poor nutritional status prior to transplant, those likely to refuse a nasogastric tube, and those planned to receive very intensive conditioning regimens, myeloablative, maybe with TBI, for example. And these were the most commonly cited advantages and problems with gastrostomies compared to nasogastric tubes across all the 36 clinicians. So the most commonly cited pros, if you like, were less tube displacements. Cosmetics featured heavily, and the ability to provide long-term nutrition and the ease of providing nutrition as well. The most commonly cited problems were the risk of surgery and infection, a feeling that gastrostomies would be a burden to the family and negatively impact the child's body image, and even that they wouldn't be used or needed. So this was really, really fascinating, because I'd just like you to try and remember some of these problems, because when I get to the parents and children's interviews a little bit later, their lived experiences of having the gastrostomies completely contradict actually what the perceived problems of the clinicians were here. So this was probably one of the most interesting parts of the project. Okay, so moving on to phase 2 now, starting with the cohort study. So the aim here was to compare all the complications, so the safety aspects of gastrostomies and nasogastric tubes, and how they compared on a range of nutritional outcomes for children having an allo BMT. So this was a single centre study done at Great Ormond Street. So we considered a multi-centre study, but the survey revealed that few of the centres were using gastrostomy, so that wouldn't have greatly increased the numbers of children with a gastrostomy. So we kept it single centre, and with Great Ormond Street being the largest in the paediatric centre in the UK, we had a big pool of patients to draw from. Now, it was observational. Children were not randomised to either tube. There were no changes to decision-making processes or pathways in any way. It was basically business as usual. And recruitment began in April 21 after we gained ethical approval and ran over 1 year. And children were followed up for 6 months from their admission for BMT until 6 months post. So that was really important. So we wanted to capture during this follow-up period, a period of time where parents obviously are on the ward using their child's tube, where they have round-the-clock nursing support. But it was more important to capture a period of time where the parents are at home alone without round-the-clock nursing support, where they'd have to effectively deal with all these complications themselves, just to see what their experiences of that was like. We kept the exclusion criteria to a minimum to maximize the sample size. So we only excluded children that received first-line TPN. That's just using some very unique and specific cases in our centre. That isn't the primary method of nutrition support. As I mentioned earlier, we use tube feeding. And we also excluded CAR-T just due to the different nature of that type of transplant. And we looked at a whole range of outcomes, any adverse events with either tube. That data was collected prospectively by daily reviews from the nurses and the doctors for inpatients. And then following the child's discharge, the children were followed up in an outpatient clinic. We looked at the child's nutritional intake of calories and protein, and we split that through their nutritional provision from all feeding routes, so their oral intake, enteral tube feeding, and parenteral nutrition. And we calculated that from a 3-day averaged intake weekly for the first 6 weeks, which then dropped to monthly thereafter until the 6-month end of follow-up. And that data was collected from the hospital's electronic patient records during the child's admission, and following discharge, parents completed food diaries following a lot of training and support via email or phone call from me. And we looked at some markers of anthropometry as well. We looked at weight and middle arm circumference changes. And this is how recruitment progressed. So we were really pleased with how this went. So we eventually got an 88% recruitment rate from every child that was eligible over the year that we were recruiting. The summary here, though, is that we finally included 24 children who had a prophylactic PEG, and they were compared to 19 children who had a nasogastric tube. And this is demographically how the children lined up at baseline. So they were comparable, really, on a number of important BMT variables. The main difference between groups was that those who had a PEG, gastrostomy, more often had non-malignancies, and those who had the nasogastric tube more often had malignancies, for example, various relapsed leukemias. Now, the likely explanation for this is the difficulty of safe timing of gastrostomy placements for those with malignancies who were going through previous chemotherapy treatments prior to being admitted for their BMT, where that issue and complication isn't such a factor with those with non-malignancies like primary immunodeficiencies. But otherwise, the groups were well matched. So I'll just go through now the some of the results. Firstly, looking at the placement and the use of gastrostomies. So most of these gastrostomies, as I said, were PEGs. They were placed in interventional radiology, IR, and they were placed at roughly about 4 or 5 weeks prior to the day of the child's transplant. And as I said, that was to allow the stoma that was created time to heal before the children become neutropenic during BMT, and thus increasing the risk of infection. Now, a really interesting finding here was that for most of these 24 children that had a PEG, it was placed at the same time as another procedure the child needed anyway for their BMT to mitigate the risk. And this was most often cryopreservation, sometimes with a central line as well. So this was really interesting. So if you just think back to the concerns of the clinicians from the survey, where the top concern of gastrostomies was the risk of the surgery to place the PEG. Well, here they were placed at the same time as another surgery the child needed anyway to mitigate that risk. So this was really welcomed by the parents, as you'll hear about shortly from their interviews. Now, both tubes were used really heavily over the 6-month follow-up, again, contradicting the concerns of the clinicians from the survey. So at the point of discharge home following the BMT admission, all children that started with a feeding tube, PEG or NG, were discharged home with it following their BMT admission. And at the point of discharge, about 80% of children who had a PEG, 70% an NG, needed ongoing enteral nutrition support because their oral intake hadn't yet recovered to allow that to be stopped. And by the end of the 6-month follow-up, all children that had a PEG and 70% an NG tube were using it to give the many, many medicines that they need every day throughout BMT. And 50% that had a PEG and 25% an NG still needed ongoing enteral nutrition support 6 months post BMT. So that just shows the really severe negative impact the conditioning really had on the progression of these children's oral intake following BMT, and how useful actually both tubes were. So of the children that had an NG tube, all of them had at least one problem, one complication with it during the 6-month follow-up. The most common complication with that tube was dislodgement. Now, really unfortunately for 6 of the 19 children that started with an NG tube, nutrition support via that route failed, and they needed a reactive gastrostomy placed post-BMT to enable them to be safely discharged home. So that clearly prolonged their admission a little bit longer, which wasn't welcomed by these families. And during the interviews, this was really the only group of parents where, when asked if you could have gone back to the start of your child's BMT, would you still have chosen the same tube? Clearly, they wouldn't have done. They would have changed their mind. So that was quite interesting. On the other hand, about 90% of children that had a PEG had at least one complication with it during 6-month follow-up. But again, as the same as the findings from the systematic review, the majority of these complications were minor, very easily treated. The most common were mechanical, the tube leaking or parts breaking. Infection and inflammation made up a much smaller percentage of the observed complications. And this graph shows the contribution to the child's estimated calorie requirements over 6-month follow-up. And there's their contribution from their oral intake. So you can see this hits a nadir by week 2. As expected, that's when they suffer the most severe side effects of their conditioning. But it did increase towards meeting their full requirements by months 4, 5, and 6. And that's the contribution from enteral tube feeding, NG on the left, PEG on the right. Broadly, there wasn't much difference between either tube at any time. And TPN made up the shortfall over the first couple of months. But statistically, really, there was not much difference between either tube at any time point. They were as good as each other. And this graph shows the change in the child's weight and mid-upper arm circumference over the follow-up. So as you can see here, those with the PEG, the green line, were slightly better nourished on admission, but those who had the NG didn't really make up the difference by the end of follow-up. But again, statistically, there were no differences between either tube at any time point. They were as good as each other. So moving on to the final part of the project. So this was the family interview. So this is my favorite part of the PhD, and I think really the most interesting and the most impactful. So I interviewed parents and children, and I used slightly different methods to interview them. So starting with the parents, so they were invited to take part in semi-structured interviews. And I interviewed parents whose child had either an NG tube or a PEG to get both sides of the argument clear. That was really important to hear both sides of this story. Topic guides for the interviews were informed by the literature, the PPI group that was supporting the study, and the earlier survey that we did as well. And each parent that was interviewed twice. So firstly, on their child's BMT admission to explore decision-making, really why they chose one tube or the other. And those were some of the topics that we covered in that interview. And each parent was then interviewed again a second time, a couple of months post their child's discharge home. As I said, to give the parents time using their child's tube at home alone without round-the-clock nursing support, so they had to deal with complications themselves. And the focus of this second interview was focusing on the day-to-day lived experience of using either tube and how that compared. And those are some of the topics that we covered in that interview. So these interviews were recorded, transcribed, and thematically analysed. And this is how parents were recruited into the interview. So all of these parents had children that were already in the cohort study. So this wasn't a separate group of parents. Their children were in the cohort study that was running simultaneously. So I interviewed consecutively 17 parents whose child had a PEG and 16 whose child had an NG tube. Those interviews continued until we got data saturation. So I didn't need to interview all these parents. Now, children, on the other hand, were generally quite young in this study. As I said, we do see the little ones at Great Ormond Street. So the average age of the children in this study was about 5 years of age, and the range was about 4 up until about 10 or 11 years of age. But we didn't really set age as a cutoff as an exclusion criteria per se. So we invited any child that was willing and able to talk about their tube to take part here. And we used some creative methods to help try and hear their voice and help them articulate their thoughts and feelings. So on their BMT admission, they were offered a scrapbook. And they could use this in any way they wanted. They could add notes, drawings, pictures, use it as a diary to note down anything they were thinking or feeling about their tube. And that would then act as an aid memoir to remind them of their thoughts and feelings during their interviews. Now, this method really suited the lengthy BMT admission, which, as we all know, is a couple of months or so, sometimes shorter, sometimes a bit longer, depending on what happens. And particularly the fluctuating condition of these children, where some weeks they're really well, other weeks they're really unwell. So they could dip in and out of this method as they were able to. Now, what I really found doing this part of the project was that building a really strong rapport and a really good relationship with the child and their family was key to getting the most out of them regarding talking about their tube, as well as the help from the project advisory group, which included the ward play specialists that do this type of scrapbook work with children day to day as part of their jobs, as well as the hospital teachers that spend a lot of time with the children as well. So they help them with the scrapbooks, as well as the nurses and the parents as well. It wouldn't have been possible without their help. And this is an example of how a child that had an NG tube used his scrapbook. So he did some mind maps with his mother. He wrote about reasons why he wanted his NG tube and things that worried him about it. And this slightly older child that had a PEG used it more like a diary, just jotting down some notes as they came into her head. But regardless of whether it was a child's or parent's interview, they were all thematically analysed, which involved familiarization with the data, inductive coding, searching for themes, reviewing the themes, and then defining and naming the themes, and drawing lots and lots of mind maps, of which this is one example. There were many, many others, just helping me kind of understand what was going on with this data and move from the inductive codes towards the themes that we identified. And I'll go through some of those now. So to me, I think the most prominent theme that captured the decision-making process I called a delicate decisional balance. And this just captured the myriad of factors that parents and children are delicately balancing the pros and cons of either tube before ultimately making their choice of tubes. And the most prominent factor in this decisional balance was this juxtaposition, this balancing of risks with either tube, that being the risk of dislodgement with the NG tube on one hand, balanced against the risk of surgery with the PEG on the other hand. So for many parents that went for the PEG, they just viewed it as a one-off procedure that their child would just have once, they could then forget about it. The tube isn't going to come out like the potential risk of the NG might be. So that was very welcoming, really, to them. They could focus then on the more important aspects of BMT. And as you heard earlier, in many cases, the PEG was placed at the same time as another procedure the child needed anyway to minimize the risk. And the parents absolutely loved that. In the blue italics here are some quotes from some of the participants. I won't read all of them out. I'll leave you to read some of them, but I will read some of them. Another really prominent factor in decision-making was the length of need for the tube. Now, at face value, quite simply, this went as you might expect. So parents that thought their child would just need their tube for a few weeks, short term, they often chose the NG tube. Those that felt their child would need it much longer term, for a few months maybe, often went with the PEG. But actually deciding which way that would go for any child was much easier for those that had some experience, some previous experience of a feeding tube to draw upon, as was the case for this family, where this parent says, for my other daughter, I knew the PEG would help because she can have it for as long as she needs. If there are problems after a BMT, it's still there. So this family clearly had some previous experience of a PEG, so they chose that again for their other sibling having a BMT. Some families had no previous experience to draw upon, so they were effectively guessing how long their child would need the tube for, and that was really hard. Cosmetics featured really heavily in decision-making as well, as it did in the survey from the clinicians earlier. This mother family had a really unique experience of the child starting with an NG tube, which failed during BMT. So the child had a reactive gastrostomy placed post-BMT so they could be discharged home. And this mother says, with the NG on her face, I experienced a lot of questions. It was drawing attention, which bothered me. I don't want to have to explain to strangers what's wrong with my child. I don't want everyone's pity. So that was a really powerful and emotive quote. Parents also considered their child's age. Quite simply, those that seem to have younger children, typically under one, felt they'd be fine with the NG. They expected it to be dislodged potentially many times, but they felt they could get it back in quite easily. Whereas those with toddlers felt the tube was going to be pulled out again and again and again, so they often preferred the PEG. And when it came to the older children and teenagers, it really came down to how they felt about the visibility, the cosmetics of a nasogastric tube being visible on the face, particularly when they were allowed back in social situations and particularly school following BMT. Parents also considered how active their child was. If they were very active, like this example shows, they often preferred the PEG. He's a very outdoorsy boy, constantly on his bike, climbs, he rides. It needed to be something that could be concealed. I felt the NG was going to be pulled out constantly. So that family had a PEG and did very well with it. And parents also considered the comfort of either tube. The NG seems a really uncomfortable thing to happen through the process of an already horrible experience of your child having a BMT. And finally here, parents also considered their child's nutritional status at the outset of BMT. If they were in a poor nutritional status and consequently expected nutrition support to be needed longer term, they often went for the PEG. So what about their day-to-day lived experiences of either tube? How did they compare? So there was a few themes that captured that. So firstly, parents and children saw either tube, the NG and the PEG, as an asset to them rather than a burden during BMT. It reassured parents that regardless of how unwell their child was, they could get all the nutrition, fluids, and all the many, many medicines that they needed, regardless of how unwell the child was. And this child here really loved her PEG, so she could have all her medicines down it, which she couldn't take orally. Quite frankly, none of the children in this study could take all their medicines orally. And both tubes far exceeded the expectations of parents and children when comparing their responses between their second interview compared to that at the beginning of the child's BMT. So both tubes were used more often and needed for much longer than anyone expected. Like this parent said at the beginning, I didn't give tube feeding much thought, didn't consider it a big part of treatment, and it's huge. And parents showed great resilience, regardless of how much they had to use their child's tube every day to give all their feeds, all their medicines, and deal with the complications. They just got on with it and they could handle it. And this was a really good example of resilience of a mother whose child had an NG tube, where her child, I think, vomited out the NG tube at home. the mother needed to give the medicines at particular times, which the child refused to take orally. They had to drive an hour to the local hospital. When they got there, they had to motivate the child to have another NG tube put down so he could then have his medicine. So you can imagine how stressful that would have been. And everybody interviewed, parents and children, wanted the choice of tubes. Even those that didn't want the gastrostomy wanted to be given a choice. And that's because it empowered them and gave them some control over this treatment that's completely out of their control. Parents should be able to decide. Every child's different. You know your child best. It should be a choice. And on this kind of theme of wanting choice, this was one of my favorite extracts from one of the child's scrapbooks. So he had a very bad experience with an NG tube many years ago during some previous chemotherapy before his BMT. So when it came around to having his BMT, he said, no way am I having the NG, I want a PEG. And he had a PEG and he loved it so much, he drew it in a heart on the left, and he'd have been brokenhearted if he couldn't have had his PEG. And he basically wrote, drinking, eating, the whole admission, taking his medicines would have been a nightmare without his PEG. Okay, so to pull everything together now, to make some conclusions. So what we found was that gastrostomy's divided opinion, particularly with differences in use across the UK centres. So was this 40-60 split. So 40% of centres were using them, 60% were not. But the clinicians generally did agree on their complications, so risk of surgery and infection being the most prominent. But despite the perceived risks, the clinicians in centres that were not using the gastrostomy did want to use them more in practice. Now, the cohort study and the interviews found that the gastrostomies were really, really popular with the families. None of them regretted their choice of having a gastrostomy. The cohort study showed gastrostomies were similarly effective to nasogastric tubes on a whole range of nutritional outcomes. They were as good as each other. And really importantly, gastrostomies were shown to be relatively safe, associated with frequent, but mostly minor, very easily treated complications. And that supported the findings from the earlier systematic review. So this actually did highlight a little bit of a paradox in that we know that there are these potential really serious risk of infections with gastrostomies in these children, but we didn't see that from the systematic review or the prospective cohort study that we did. So what explains that? What's some possible reasons for that? Well, there might be an aspect of selection bias here. Of course, parents ultimately chose this tube for their child, so you may expect them to have a more proactive approach towards the care and management of the gastrostomy, basically picking up problems quite early before they become quite serious. And that would be the same for the clinicians. There might be an aspect of overcompensation, in that they very diligently monitor the gastrostomy and pick up complications early before they become quite major. Now, to parents, the benefits of the gastrostomy far outweighed their risks. And the decision to use either tube, of course, requires carefully balancing the pros and cons, and maybe putting families at the center of decision making, because ultimately the parents will be the ones using the tube. And this parent said, at the end of the day, the parents know best. They're the ones that are going to have to look after the child. They're at the forefront of everything, so they should be given a choice. And just to finish with the recommendations, so we recommended that if an NG tube isn't going to be feasible, then choice for gastrostomy should be offered and on the table. And just to clarify, I'm not saying that all children should have a gastrostomy. Many of them did absolutely fine with an NG tube, and it would be crazy to place PEGs unnecessarily in those children, but some won't be okay with the NG tube, so choice of a gastrostomy may benefit them. Pre-admission counselling will help families understand the importance and need for a feeding tube and give them time to make a decision, but they need to receive consistent advice from clinicians to help with their decision-making and avoid any confusion. There should be an MDT approach to decision-making, putting families at the centre of that. That will give them empowerment and give them some control. Families really valued lay advice that they got from other families they know from the hospital. So consideration could be given to setting up a peer support group of other families that have gone through BMT before, so they can talk about their experiences of tube feeding. We showed that it was possible to place many of the gastrostomies at the same time as another surgery the child needed anyway for BMT to minimize this surgical risk. And for those with no previous experience of an NG tube, consideration could be given to a very brief, quick trial of an NG tube before the child's admitted for their BMT to see if it's possible And if it isn't, then a gastrostomy could be considered, and that will prevent them needing that place reactively and delaying their admission and discharge, or prolonging their admission following BMT. And children wanted to be involved in the decision making wherever possible, of course, depending on their age and ability. So if anyone's interested in reading more about this, we've published most of this work now, some of it available open access on these links. We're trying to publish the qualitative work from the children and their interviews in the scrapbooks currently. And these are some up-to-date references in this area, which I hope you find useful. So thanks, and acknowledgements finally to my supervisors, particularly led by Professor Faith Gibson, and all the parents and children who took part as well in the research. Thanks very much for listening. I hope you enjoyed that, and I'll welcome any questions.
Thank you so much for that presentation, James. Yeah, you might want to stop sharing. Yeah. First of all, it was really comprehensive, very logical. And actually, I love the approach where you use quantitative, obviously, methods and qualitative, and it really shows in those different studies that complement each other really well. So, I mean, I got a few questions, but I'm just going to let others ask any questions if you have any. No? Okay, I'll make a start. You can also put the questions in the chat if you prefer. We got 15 minutes, really. So I guess my question, I think this is quite general. Where do you want to take this project next? Obviously, you got important findings here, particularly in terms of the gastrostomy tube feeding. Yeah, where do you want to go next, really?
Yeah, absolutely. Great question. That is on my mind. So I think the really important, I think one missing piece of this puzzle is doing the kind of qualitative work with the clinicians, the decision makers in all of these different centers. Particularly in those that are not currently using the gastrostomy. So it may be kind of that you find there are really kind of structural, I don't know, problems, facility problems, like they might just not have capacity to do these surgeries, for example.
Yeah.
There might not be the willingness of commissioners to commission the cost, for example, of placing gastrostomy. So economics might come into this as well. So there's probably a need to do an economic evaluation and try and understand what goes on in all of the centers, and maybe compare that between those that do it to see how they operate that. So clearly I've got a good idea of how that operates within Great Ormond Street, where we do the pre-admission consultations and everything is planned a number of months before the child's admitted. So that could be potentially a model that's replicated in other centers, but it would be really nice to look at how other centers are doing it and how they operate it, and compare that to how centers that aren't doing it, why they don't do it, and look at how they could perhaps implement it. So there's a need here for qualitative work with the clinicians, economics, and kind of some implementation science approach, probably. I mean, that's my thinking of it.
And I think, thank you. Yeah, it really makes sense, the economics aspect, which is at the moment, I think most research is really considering now. Otherwise, applicability is really hard into the translation into clinical practice. Oh, I thought there was a question. It's not a question. Any questions? No, I'll read the comments. So thank you very much. This is from Maya. It was very interesting. I really connected with an approach that allows parents and children to be partners in the decision. Super important.
Thank you.
I think so. Your research, you primarily look at nutritional outcomes.
Yeah.
And does it seem to be a huge difference in terms of whether you use an NG or a PEG?
No. Yeah.
If I understood correctly.
That's exactly right, Raquel. So we didn't find much difference. So we did mainly we focused on nutritional outcomes here. We looked at the child's intake, we looked at their weight change, mid-upper arm circumference as well. And what we kind of uncovered was both tubes were as good as each other, really. There was no kind of major differences. I guess what we did highlight was that how useful each tube was throughout the 6 months of follow-up. So both nasogastric tubes and gastrostomies we used really heavily to give them medicines that the children needed, as well as give them nutrition support for as long as they needed as well. And that kind of countered, I think, some perceptions of parents at the beginning where they don't think either feeding tube is really going to be that useful. And sometimes I think you do get that from some of our medical colleagues as well. I mean, I know that varies from MDT to MDT and center to center, but some of them are, not so pro tube feeding as well. So it was really good that we showed how useful they were, both of them, even though there wasn't really much difference between either of them.
And in terms of, and I don't know if you look at this or perhaps you read in the literature, whether there is any associations, not just with nutritional outcomes, but perhaps with other side effects aside the specific tube feeding, side effects, complications, or general clinical outcomes.
Yeah, I mean, the only other thing really that we looked at here was this kind of safety aspects, like the frequency of all the problems, the complications that happen with the tubes. And as we found out in the systematic review, there was quite a lot of evidence that had looked at this in this population. Generally, the quality of the evidence was kind of moderate, really, at best, because that was an important thing to look at in this study. Clearly, from the earlier PPI work that we did, and what we uncovered from the clinician's survey was that the risk of infection, particularly, and surgery was a really big barrier to the wider use of the gastrostomy. So really, we just looked at those kind of adverse events and safety aspects of the gastrostomies and the NG tubes, and found that, gastrostomy complications did occur frequently, but they were mostly minor, very easily treated. But even, you have problems with NG tubes as well, where they're dislodged very, very frequently. But we deal with it, and we replace NG tubes as an MDT and working with the family, and we get them back in if we kind of need to. So that was the only other major thing that we looked at there, and that seemed to be what other authors had looked at in the literature as well.
Yeah, interesting. And in terms of, so obviously you presented your recommendations at the end. So how are you using that in your practice? Did you, for example, I found one of the final slides when you're presenting the balancing, the balance between what the parents thought it was important, which is also dependent on the child's age as well. Do you talk about that with the families, now, having learned from these experiences already, this research?
Yeah, absolutely. And that theme to me was just so interesting, because certain bits in that decisional balance will be more important to some families than others. So for those that do have toddlers, that will almost be the first thing that they go to. They will just know that their child won't keep an NG tube, and they'll pull it out all the time. And that will kind of be one of the primary decision makers there. For the older children, they're not too bothered about that, but those older children, their parents are more bothered about the aesthetic. So it's very, very individual. I guess what I'm kind of working on at the moment is maybe some patient literature that's quite simple, that does use all these findings that we've uncovered in these interviews, so we can help parents make and children make that decision making. So that's kind of really how we've implemented it in practice.
Yeah,
we do the pre-admission counselling here at our centre with an MDT approach. We haven't yet managed to implement, I don't think, the trial of an NG tube for those with no previous tube feeding experience. I think that would be really useful. Clearly, that is a little bit difficult to kind of work out how we do that. So that's something that we're working on at the moment. But I think definitely developing some patient literature using the findings from this research that quite simply helps them make this decision somehow.
Yeah.
Might be a little tick box where they, I don't know, rate different things and balance it up for them, maybe something like that. But that's a work in progress.
Absolutely. We got a question here. So it's saying, you mentioned that there were no significant differences in nutritional outcomes between the two tubes, but did you see less vomiting in PEG?
Yeah, do you know, we didn't look at the frequency of vomiting, diarrhea, stool output, actually. So that I can't answer that question. We didn't specifically look at that, and I know there are some validated tools where you can kind of look at those types of outcomes. What we did find with the NG tubes, as I said already, dislodgement of that tube, primarily due to vomiting, was a big part of the quantitative complications outcomes that we looked at. And it was a really emotive thing in the interviews as well, where parents spoke about having to have their child's tube repeatedly replaced, which they didn't like that at all. Vomiting really didn't come up much in discussions with the PEGs, but I didn't look at it quantitatively specifically, so I can't really say if we had less vomiting per se with that.
Okay. Thank you. Right, I think we don't have any more questions. We're just going to close the session. But before we go, can I remind everybody that there is an annual meeting for the Nutrition Network on the 2nd of December. It is 9 a.m. Central European Time, 8 a.m. UK time, and you can work out the other times as well, but it's on the SIOP website. And I'd just like to thank James again and everybody who joined us today. It was a lovely presentation, really, really relevant clinical practice. So thank you.
Thank you, Raquel. Thanks, everybody.
Okay, and see you.